HIV and Opportunistic Infections today. It's very generalized overview. I know I've been given the hour to do it, but I don't have the attention span to talk for an hour, and trust me, you'll get very bored of my voice very quickly. So let's just get started and see how far we can go. So, case 1, 43-year-old gentleman presents to minors with shortness of breath for about 8 weeks now. Okay. It's worse on exertion. It's associated with a dry cough, night sweats, weight loss of about 6 kilos in the past month. And in the past day, acute deterioration. Now at rest, associated with chest pain, worse when he takes a deep breath in and when he has a cough. Okay. It's on examination, you're doing predominantly a respiratory examination, right? But you're also doing cardiovascular exam, but slightly reduced expansion on the right side. Trachea is displaced to the left. It's hyper-resonant on the right side. Reduced breath sounds on the right, otherwise vesicular. He's 28 respirate, and his SpO2 is 92 at rest. However, it drops to about 84 when he ambulates. So, why is this now being so finicky?
Do you want me to control it and speak? Because I'll do that.
Yeah, would you mind? Because I can't get the animations to go.
Cool.
Thanks.
Yeah, cool.
So first, what is your immediate management of this patient? I'll monitor the chat for a moment just to see.
So this might be a familiar presentation in coronavirus, but like...
Niraj, how do you know it's a pneumothorax? ATE assessment, fantastic. So you he's in minors, he's generally stable. He's generally stable, so you don't need to do an ATE assessment. He's stable enough that you can treat him in minors. So yeah, high flow O2. Okay. Remember, guys, what have I told you since 4th year? Right? You got to be systematic with how you do things, right? So always start at the bedside before you go to radiology. Okay. So yes, chest X-ray is correct, but it's not what you're going to do first off in your bedside to imaging, right? Yeah, obs isn't technically investigation, but yes, you would do observations. You would do, again, VBG, okay. What would you do before VBG, before you do any bloods? Yeah, you can do, I don't disagree with peak flow. Anyone presenting with shortness of breath, especially if they have a history of asthma, and they have an audible wheeze on examination, I do a peak flow. Yeah, I'd agree with that. Anything else you would do by the bedside? What if I told you this patient was traveling a long-haul flight? Yeah, an ECG, right? You want to do ECG. BP is part of your obs. Yeah, so you're going to do an ECG first. Fine. And then you're going to do bloods. First off, I wouldn't go to a VBG because you're just... it's kind of pointless just doing a VBG. The patient's SATs are below 94%, so you're going to do an arterial gas anyway. So you're going to do your gas, okay? Your arterial gas. What other bloods would you do at this point? I mean, you're going to stick a cannula in this patient, and you're going to do bloods. They want, septic screen, FBC, using EC. I don't disagree with the cultures. I think doing cultures in CRP is fine because I didn't tell you this patient's temperature. They're coming with the night sweats and fevers. It could be an insidious infection. So yeah, that's very good. LFT is very good. You're going to do baseline LFTs because you're eventually going to treat this patient with antibiotics, and you want to know what their baseline liver function is. Jessica, you're guessing TB and HIV because this is a talk about HIV, but yeah, I don't disagree with testing for those two things either. In someone who's lost weight over such a grand amount of weight over a short period of time. I don't think it's, difficult to say. Difficult to say. I think you would want to because of the weight loss, the insidious fevers, the dry cough and the shortness of breath would want you to test for TB, okay? HIV, if you're going to test for TB, you would test for HIV because they're both mimics of each other and they can both coexist in patients as well. Yeah, I think, and especially in London as well, Izzy's got a very good point where the prevalence is relatively high. You would still, I think if the prevalence is above 2 per 1,000, you would test people for, you would routinely test people for HIV. But I need to remember that number exactly. So good, fine. So you've done all those basic things. Now this is just a very brief overview of general medicine. Fine. So this is the chest X-ray done. Anyone want to take a stab at what they see? What's the most glaringly obvious abnormality? And I agree with you, Niraj. I think anyone presenting with insidious shortness of breath and weight loss, you should also work them up for lymphoma, especially if the chest X-ray shows something like a mediastinal widening or a mediastinal mass. Anyone got any idea what's on the chest X-ray? Yeah, very good, Jessica. Right apical pneumothorax. Very well spotted. Okay. Yeah, very good. Very, very good. Very good. Do you mind doing the animation? Sorry.
Yeah, sorry.
No, it's okay. It's okay.
So this was all of their stuff, and then we've got the right apical pneumothorax, and then there were also these findings. If you want to talk about them, Mark.
Yeah, so I mean, it's very faint, and I don't blame you for not seeing it, but there's some reticular shadowing in the particularly in the mid zones with a bit of, yeah, I mean, it looks like a Gunji X-ray in general, but particularly in mid to lower zones, there's a bit of reticular shadowing that's not that obvious. And that tends to be a classical presentation of what I'm going to be talking about later. The chest X-ray isn't very nonspecific. Now, this patient is an IVDU, right? Shares needles. They have no other risk factors. Their ECG is fine, okay? They're not tachycardic, right? And there's no other abnormalities. Their ABG. Who wants to take a crack at interpreting this gas for me? I just wanted to throw in a bit of revision of your gen med. Yeah, it's on room air. If it wasn't on room air, you'd still be very worried. But good question to ask. What's the glaringly obvious abnormality of this ABG? Okay, so Niraj first. Right. Type 1 respiratory failure, correct. Okay. They're hypocapnic. Yeah, probably because they're hypoventilating. SOMAR, alkalosis is correct. It's not it. Jessica's got it right. It's respiratory alkalosis. Okay. No, there's no compensation. Patrick, the bicarb's in normal range. So 22 to 26 is actually the normal range, I think. But it depends on your gas machine, and they'll usually give you the. I should give you a reference range. Sorry about that. Fine. What about the calcium and the potassium? You're correct in saying this patient's type 1 respiratory failure. They're hyperventilating, so that's why they're offloading their carbon dioxide in there, giving themselves the respiratory alkalosis. Very good, Niraj. Hypocalcemic because of the respiratory alkalosis. Yeah, so they're hyperventilating. The low potassium, very good. So they're hypokalemic. Why are they hypokalemic? It's not a severe hypokalemia. It's a very minor hyperkalemia, but it's something that you kind of see. So do you want to explain the mechanism there, Niraj? You're on the right track. It's not the hyperventilation that's well, indirectly it's the hyperventilation that's causing it. The hyperventilation is causing the respiratory alkalosis, and then the alkalosis is causing the hypokalemia because you got there. So yeah, the alkalosis is causing the hypokalemia because your cells, when you're in alkalosis, your cells will try and fire out hydrogen for potassium. Okay, so they'll absorb potassium, dropping your serum potassium, and then in acidosis, correct, Patrick? It's the other way around. Your cells will absorb hydrogen ions, and they'll fire out potassium ions in exchange. Okay, so it's something very common. I mean, like when I was on ED for 4 weeks, and I ended last week, and I mean every patient that came in with COVID that was type 1 respiratory failure, was hyperventilating, had this on their gas. So it's quite a common thing, especially if someone's hyperventilating. Good, fine. So in terms of the pneumothorax management, just a quick reminder, this is the BTS guidelines. I would go over it. It's a very good flow chart. And the main things you're looking for are they primary, secondary pneumothorax, okay? And then you're looking at the size, okay? And depending on the size and whether they're symptomatic, you're either going to aspirate, okay? Well, you're either going to see them in clinic, discharge if they're okay, see them in clinic, aspirate. If the aspirate is successful, then you'll see them in clinic. If it's greater than 2 cm, you're going to put a chest drain in, okay? And it's a secondary pneumothorax. If it's a secondary pneumothorax and it's 1 to 2 centimeters, you're going to aspirate. If the aspirate fails, you're going to stick a chest drain in and admit. Either way, in a secondary pneumothorax, you're going to admit for observation anyway, okay? But this is a very good flow chart. Just remember the BTS guidelines when it comes to pneumothoraces. So, in terms of epidemiology of HIV, the overall prevalence currently is about 2 per 1,000 people. This can rise up to about 5 per 1,000 in specific areas, particularly highly dense areas, such as London and Manchester. Okay, and there are particular at-risk groups. Do you guys remember from my last teaching session which are the at-risk groups? Yeah, IVDU. Yeah. People immigrating from endemic areas, MSM. Good. Okay. So, yeah. And don't forget those who solicit and are also sex workers as well are at risk. So these are important groups that you need to keep in mind when you're taking a history from a patient, okay? But good, well done, you remember. Good. Very important next is the transmission routes. Izzy, you've given away half the answers.
Oh, sorry.
Okay.
There's not the interventions.
No, it's fine. Don't worry. No, it's all right. Don't worry. Fine. So these are your transmission routes: sexual intercourse, contaminated needle, vertical transmission, and there's also organ donation as well. I forgot to put that down. In terms of interventions, why don't you guys give me some interventions that you can suggest to prevent transmission through sexual intercourse? Yeah, condoms, very good. One more. Yeah, pre-exposure prophylaxis, post-exposure prophylaxis. Good. How about contaminated needles? What can you do for patients who are IVDU and are at risk of using a contaminated needle? Yeah, needle exchange programs, very good. Needle exchange. You can also give them PrEP as well, post-exposure prophylaxis if they think they've used a contaminated needle. How about vertical transmission? Yeah, healthcare workers, needle stick prevention, very good. Yeah, HIV testing early in pregnancy. So we do it at the, oh god, I can't remember now. It's during the first antenatal visit.
I think it's at booking visit.
Yeah, that's correct. It's at booking visit. Yeah, and then you can avoid breastfeeding. You treat any positive HIV during the pregnancy. You can treat the baby antenatally, and you avoid breastfeeding. Very good. Okay, brilliant. So in terms of HIV virology, do you guys know what type of virus HIV is? Yeah, it's a retrovirus. And what retro means is backwards. So it works backwards. So it actually stores its information as single-stranded RNA, unlike a majority of other viruses. And what it does is it uses an enzyme called reverse transcriptase to convert that single-strand RNA into DNA, which it then incorporates into the host cell cleverly, tricking the cell to produce its replicates, okay, which then bud off and then complete the cycle over and over and over and over again, okay? So host cells then produce new viral material, forming new virons, which bud off the cell, and ultimately this becomes too great for the cell and kills it. So if we just skip ahead, this is a very good diagram that Issi's come up with that I will come back to when I teach you guys about HIV drugs. That will be a short session that I will do. But this is a very good diagram that demonstrates the point. So what I'm going to talk about next is the glycoprotein 120, CD4 receptors, and then it goes into reverse transcriptase. So yeah, it preferentially targets CD4 T cells, macrophages, and dendritic cells. It fuses to the membranes through the GP120 and CD4 plus chemokine receptors. Okay, these are important ones to remember because they probably will come up as theory questions. Preferentially makes its way to the lymph nodes where it propagates amongst other CD4 T cells. Okay, and then during the primary infection, you'll notice a spike in HIV replication and CD4 replication. CD4 proliferation while it first begins to brood, okay, and replicate. And then, if you go without treatment, you'll notice that there's a steady decline of CD4 cells and a steady rise in viral load up until a point where it reaches a CD4 count that's so low and a viral load that's so high that you're susceptible to opportunistic infection, okay? And that's when it gets very dangerous. That's when you have acquired immune deficiency syndrome, okay? So if we just move on. Good. So this is a very good diagram to keep in mind when you think about the timelines and the stages of HIV. And so, like I said, there's a transient spike in viral load that steadily declines and rises again, and then there's the steady decline in CD4 count over time. Okay. Good. So there's the stages of HIV. So we've talked about the transmission of HIV, and then I'm going to talk to you about the early stages, okay? So there's seroconversion illness, there's the latency period plus primary generalized lymphadenopathy, and then there's early symptomatic HIV, and then there's acquired immune deficiency syndrome, okay? So let's talk about seroconversion illness first. So this is usually 2 to 4 weeks, or up to a month, up to 6 weeks after a patient acquires HIV. And they may experience a flu-like illness, may be very non-specific. I mean, you just throw your non-specific illness symptoms: fever, malaise. They may have some weight loss. They may have night sweats. Okay, but they may sport some skin manifestations, and this is one of them. I don't know if has anyone done the GP dermatology session that you do in 5th year. This is a question that this is one of the spot diagnoses that come up. Does anyone know? Anyone got any idea what the rash is?
I'm not even sure I remember what the rash is called.
No, that's all right. So it's a pruritic. It's very itchy. So it looks papular, right? So it's a pruritic papular rash, or pruritic papular eruption, because it just suddenly comes up. Okay, so this is it's not pathognomonic, but it is indicative of HIV, especially in the early seroconversion illness. And then in severe acute HIV, you can get neurological manifestations. You can get motor, sensory. You can even have patients presenting Guillain-Barré. I was reading a report about it the other night. And then there's even patients who might primarily present with something like progressive multifocal leukoencephalopathy. Okay, which I'll talk about that a little bit later. Good. So that's seroconversion illness. That's the first early stages. And then you go into clinical latency period, right? And this is a period where generally people are asymptomatic. It can last a couple of months to years even. They may have nonspecific signs again, and they may come up with primary generalized lymphadenopathy. So you can see in the patient in the lower left, he's got, does anyone know which nodal chain that is? Or which lymph node that is? There's a very specific lymph node. Actually, that one is a very specific lymph node. Good finding, Izzy. That's a good one to test them on. Anyone got any idea?
Sylvia said submandibular.
Close. Okay, you're close. I mean, it's a little far back to be submandibular. That is the jugular digastric lymph node, and it is it. I can't remember what specifically it is a sign, like it comes up in, but it is an anatomical one that neck surgeons like to talk about, if I remember right. And then in the right, the picture on the right, you're correct, Sylvia. There's the lowermost one is his submandibular lymph nodes, and then he's got preauricular and his jugular digastric there. Good. And then in this period, this is when I was talking about the HIV virus makes its way to the lymph nodes and it replicates in the lymph nodes, and you can get a specific form of Castleman's disease, which is the proliferation of these lymph nodes, is multicentric Castleman's disease. That's not important for fifth years, so don't worry. But just for anyone who's curious, just look up Castleman's disease. Okay. Good. So that's the clinical latency, and then you have early symptomatic HIV. Okay, and this is when the CD4 count, as it's steadily declined, it's reaching its lower end. Okay, it's CD4 count of like 400, 300, just before the 200 mark. And you're starting to see early manifestations of symptomatic HIV. Okay, so immunosuppressive consequences. Okay, and you guys know there's three pictured here at the moment.
So these two are the same?
Yeah, the bottom two are the same. But the top one is a very distinctive one. Yeah, oral hairy leukoplakia. Very good, Jessica.
Good. So that's that one.
Yeah. So that's the one on the tongue. Nope.
And then for these, if it's not obvious, it kind of, how would you describe them, Mark? Yeah.
Well, okay. Well, I've lost the slide hold on a second. Let me just move my slide.
Niraj actually got it. So it is seborrheic dermatitis.
Yeah, very good. Looks
like this flaky skin here, so they can get that in HIV.
Yeah. Very good. Very good. Seborrheic dermatitis. Yeah, and it's very common. And then there are others. So you can get varicella zoster. You can get oral candidiasis. You can get idiopathic or thrombocytopenia purpura. Okay. Sorry, I've lost the view of the slides. I'm just going to try and exit and re-enter. If you move forward one. And see if I can...
Has it come up with the AIDS slide?
No, it hasn't actually. Hold on. Let me see what happens if I take control.
Hold on.
Is it moving for you guys or?
You're on early symptomatic HIV.
So
is that correct? Is that what you're saying?
No, I'm not seeing anything. I'm just seeing a blank screen.
Here, can you get up the slides like on your? Hold on, we've lost them now.
Yeah,
can you get up the slides on your thing and then, like separately, and I'll just continue on mine because I think your things. One sec, guys. Sorry. Right, that's wrong. Right, so. We were on the AIDS slide, Mark, was what we were going on to.
Yep, brilliant. I don't know why I can't see any of this. Do you have the slides up?
They're literally just loading. Give me 1 second. that's coming on.
Brilliant. Okay, I can see them again.
Right, cool. So we're on slide 15.
Yep.
So yeah, we went from early symptomatic, and then now moving on to the final.
Very good.
Final
Yeah.
stage.
Yeah. So now this is when you're reaching a CD4 count of less than 200. Okay. This is when you start to get all the opportunistic infections, which basically are collective of different illnesses which define acquired immune deficiency syndrome. Okay. And does anyone know any of the AIDS defining illnesses?
Quite a few of them came up in fourth year. So just think back to specifically respiratory, I think, were the big ones.
Yeah, PCP, very good. Yeah, you can get non-Hodgkin's lymphoma, very good. CMV, Kaposi, TB, fantastic. Anything else? Toxoplasmosis, fantastic, very good. So you guys remember a lot of them. Anything else? Yes, you can get the lymphomas. Good. Okay, fantastic. You pretty much hit the bulk of them. Yep, cryptococcal.
Candidiasis, yep.
Yeah, candidiasis, esophageal candidiasis specifically. Okay, and then you have your TB, but you also have your non-tuberculous mycobacterium, so your Mycobacterium avium complex. Okay, and then you need to think about testing patients with HIV, those presenting with recurrent bacterial pneumonias. Okay. And very good. You pretty much hit most of them. I think the only one you guys missed was the wasting syndrome, which is an acute weight loss of greater than 10% of body weight.
But I guess we did ask them infections though. But yeah, it is.
That's true. Yeah, but very good. The rest of it, you pretty much hit every other one. Good.
Cool.
So just another point on the basics of HIV testing. Do you guys remember the difference between the two?
So there's one you can do at the bedside, and then there's one that you would be asked as probably a med student to do and then send off.
Yeah, so one is the POC antibody test, and the other is the venous sampling antigen antibody test. So what's the big difference between antibody testing and antigen testing? If you remember from the last talk, which you guys remembered from before, so I'm very impressed. AB takes time to develop. Very good, yeah. Antibodies take time to develop. Antigen equal PCR. Specifically, I think so. I can't remember exactly, but the antigen will appear first. Yeah. So you guys have it correct there. Your antigen will appear between, I think, 13 and 28 days. So it gives you like the month window. It tells you the status of the patient in the past month, whereas the antibody takes up to 36 days, if I remember correctly. Yeah. So it can give you the status for up to 3 months in general. So the negative test for an point of care antibody only test gives you the window 3 months ago, whereas the antibody antigen test will give you the window for a month ago. Okay. So let's just remember your timelines. Okay. Good.
And just for the wards, so the HIV testing is done in the red top bottle. And so for someone that comes in, they may do this test at the bedside, but you would say to them that we recommend a follow-up test because obviously this is only in the 1 month window, whereas if they had unprotected sexual intercourse 2 months ago, they'd need the red top blood test. They'd need the other one. And similarly, if they only had it a week ago, this may not be positive, and so they'd need this as a follow-up anyway, if that makes sense. But we'll do some SBAs in another session. Sorry, Mark.
Yeah. No, it's fine. It's fine. The other thing is it's not just HIV that's taken in the red top. All viral serology is taken in the red top as well. So your hepatitis C's as well will be done in the red top. Good. Okay, so opportunistic infections. Coming back to the case we talked about earlier. So very good. You managed the pneumothorax well. Patients on the ward, being monitored, improving breathlessness, but they're still desaturating when they ambulate. Okay. By the way, just when I say the desaturating ambulation, it's a very good practice to get into when you do a respiratory exam or when you're in an OSCE and you're tidying up your respiratory exam, right? Offer to do ambulatory SATs, because they might have underlying respiratory disease, but they might be fine at rest. But if you get them to walk a little bit and put them back on the SATs probe, they'll desat and kind of unveils it for you, okay? So, good. Based on the clinical scenario that I've given you, what do you guys think this is, first of all? And what do you think we're going to do to diagnose it? Very good. Bronchoalveolar lavage and a silver stain. Very good. Yeah, you can do the chest. I mean, this is a very, very severe chest X-ray of it. I mean, you're more likely to get the very faint reticular shadowing, like you saw in the first chest X-ray I gave you. But very good, Jessica. So if you're going to do a bronchoalveolar lavage and silver stain it for the diagnosis, then what is this condition? BCB.
Sorry, I gave it away.
It's all right. It's all right. Don't worry. So fine. So the presentation,
it's
fine. Don't worry. It's usually non-specific. Again, it can mimic a lot of other conditions. It's shortness of breath, particularly on exertion, dry cough, fever, night sweats, weight loss. Usually occurs at a CD4 count of less than 200. 1 to 6% of patients, I was reading the BMJ, present with pneumothorax, and this is a very poor prognostic indicator for these patients, okay? And another key one, like COVID, they tend to desaturate on ambulation. Fine. And as we said, the diagnosis was you're going to do a bronchoalveolar lavage after your chest X-ray. You can do a CT scan, and they'll have ground glass shadowing, and it is Grocott silver staining, so which is what you see here on the right. And it's either induced sputum or bronchoalveolar lavage, but they prefer. I think they do prefer the bronchoalveolar lavage. And then what is your first line treatment?
Sorry, I just really love the word lavage.
It's a very nice word.
Of course, they prefer a lavage rather than a sputum sample.
So your first line treatment, anyone? So obviously you're going to give them supplementary oxygen, and then if they need ventilatory support, you're going to give them ventilation.
Sylvia and Jessica have got it, so cotrimoxazole.
Yep, fantastic. Cotrimoxazole, and there's one more, and Primaquine. Do you guys know how long you give it for? You give it for about 21 days. Okay, good. So Cotrimox and Primaquine, you give it for 21 days, and rightly said, Jessica, if their PO2 is less than 9.3, they're basically hypoxic, and you're going to give them steroids as well. Fantastic. Okay. What was next? I can't remember whether I did that or not.
I think we should pose it as a question before we move on, because it gives the answer. So you've got someone with HIV who's on their first presentation, and they come in with loss of vision in one of their eyes, and you find there's a raised CRP, raised ESR, they're feverish, they're unwell, they're a bit confused. What would be an opportunistic infection that you'd have in mind?
This is also an opportunistic infection that you see in renal transplant patients on tacrolimus.
Fantastic. So yeah, CMV retinitis. So we will go through that.
Good. Okay. So yeah, so this is CMV retinitis, usually seen after, usually seen at a CD4 count less than 100, and then you get end organ damage at less than 50. Does anyone know which group of virus? Oh, Izzy's giving it away.
Sorry.
It's okay. Human herpes virus 5. Okay, so the other herpes viruses are your HSV1, your HSV2, your varicella zoster is your 3. Your 4 is Epstein-Barr virus, and your 5 is cytomegalovirus. Your 6 causes roseola infanatum, if I'm not mistaken. 7, no one really cares about, and 8 is Kaposi sarcoma. Okay. I think I was reading something like almost 90% of people will have this infection sitting in the background. It usually flares sometimes, and it mimics either a mononucleosis or a hepatitis. But generally, it's asymptomatic in the immunocompetent patient. But in the immunocompromised patient, it's very dangerous. So you can have retinal manifestations like we talked about, and there's a very good classic picture of what the retina looks like. Does anyone know what the name of the retina is in this case?
It resembles something that a lot of us would like to eat on a regular basis.
Think Spider-Man 2 video game and movie. The original, the best one, the Tobey Maguire ones.
They've gone for it. Pizza pie
Pizza pie appearance. Yeah, very good. Cheese pizza appearance, very good. And then you can have gastrointestinal, and you can also have nervous system. You can get a meningoencephalitis or a polyradiculopathy. Good. Your investigations, very simple. Serology. Okay, you're going to do serology for your IgG or IgM. You're going to do PCR, and then you're also going to do a biopsy plus microscopy, and you're going to see an owl's eye inclusion, which I'm very proud of the image I found because it looks like a smiley face, and that smiley face is going to turn to a frowny face if you guys can't tell me what organ this biopsy came from. Izzy couldn't, so I was very sad today.
I think of an organ that in 4th year you learn kind of causes something inflammatory and
don't give them hints. They should know from first
I mean,
year.
I didn't know either. So, and also no one can tell. Marc obviously loves infectious diseases. So, yeah.
I was so happy that I found this as a smiley face. It made my day.
So, is it in the liver, or is it in the kidney, or is it in the heart? That's 3.
Very UCL thing to do. Yeah, it's the kidney. A very UCL thing to do is to give a multiple choice question.
So that's the glomerulus, basically, which Marc pointed out to me earlier. But don't worry,
yes. And you can see just at the top left corner, you can see the tubules and the collecting duct is at the top left corner of it. Good. And then you're giving ganciclovir for 2 weeks, and you're continuing prophylaxis with ganciclovir for retinal disease until, let me just double check, the CD4 count is above 100, and that's usually about 3 to 6 months. Okay. Not that important.
This is a very small part of HIV, though, guys. So I think just the take homes would be in someone who's got visual disturbance, and you're going to treat them with antivirals.
Ganciclovir. Okay.
Yeah.
But the other thing is, if you're suspecting meningoencephalitis and you're thinking cytomegalovirus, again, ganciclovir. So the main thing is, when you hear cytomegalovirus, think ganciclovir. Okay. What was the next one?
The Q case.
This is based off a case that I actually saw as well. This is a very interesting case. So, lovely. Fine. So this was a very nice 19-year-old lady who had immigrated from Chad, and she had a pet cat. And one day she woke up and she was just unable to move her left upper limb and her left lower limb. Words there, but yeah. So, and she had one episode of loss of consciousness, unwitnessed, but she felt really, really terrible afterwards. Sorry, that's supposed to be the other way around. She had right limb was totally normal. Her left limb had spastic hypertonia, 3 out of 5 weakness, globally, and hyperreflexia, and the same for the lower limb, except that it was spared some of the weakness. Sensation on the left side was normal. Cardiovascular exam was normal. Why am I doing a cardiovascular exam in a patient presenting with upper limb and lower limb weakness? Important for being an all-rounded physician to think laterally, especially in young patients.
So in someone with focal neurology, why would you do a cardiovascular examination?
In someone with focal neurology, you're going to do a cardiovascular examination as well. And you're also going to listen to their neck. Yeah, one of the causes, you can have carotid artery dissection as it, but commonly you're going to do a cardiovascular examination. Yeah, because you can have cardiovascular causes of stroke. That's very good. So you're looking for signs on examination of stroke. So irregular pulse, irregular sounding heart sounds. You know what I mean? Very good.
Yeah,
So
good.
what is your differential based on a young woman who is immigrated with sudden onset weakness?
And this is a HIV talk.
Yeah, fine. You want to, yeah, okay, fine. So we said stroke as your differential. Yeah, toxo is going to be, I mean, it wouldn't be your first differential, but yeah, it is worth in a young patient with acute onset lower limb weakness and upper limb weakness. Yeah, you're going to go for meningitis as well. Very good.
Cool.
Yeah, so
there we go.
good. So they decided to stick her in the MRI scanner. Because they found something on CT that just didn't look right. So they put a bit of contrast in, they stuck her in the MRI. And then they found this. It's a ring enhancing lesion. Okay. So you know a ring enhancing lesion because as what it says. It's an area of decreased density surrounded by increased density because of the dye. And a good mnemonic for it is Dr. Magical. And I don't expect you to know these off the top of your head, but the D is for demyelinating diseases, so MS, okay, and PML. The R is for radiation necrosis or resolving hematoma. The M is for metastatic disease. The A is for abscess. The G is for glioblastoma. If anyone can name a very famous drummer who died of glioblastoma a couple of years ago, I'd be very impressed. The I is for infectious or inflammatory. Sorry, infarction or inflammatory. The C is for contusion, cerebral contusion. The other A is for AIDS, so cerebral toxoplasmosis. And the L is for CNS lymphoma. Okay? So this is a good mnemonic to remember when you're on neurology and someone says, what are the causes of ring enhancing lesions?
The
Good.
two big ones for this patient would be the cerebral toxoplasmosis, but also the lymphoma due to the HIV. So
Yeah,
Jonathan
very good.
Cartledge talks about this a lot. Obviously you'd have these in your differential, and for neurology in general, it's good to say like demyelination or malignancy or infarct. But for these would probably be your top two that you're going to try and distinguish for this patient.
Well, the other thing is patients presenting with lymphoma will be worked up for HIV as well.
Mhm.
So you can have a patient presenting with primary lymphoma, but you are going to do serology for HIV as well in them. Okay. You will do hepatitis and serology in them as well. Good, fine. So these are another two images of cerebral toxoplasmosis. Another very good ring enhancing lesion on the left. Why did Izzy put pictures of cats in the talk? Yeah, cat feces is toxoplasmosis is predominantly found in cat feces. It's also found in unwashed vegetables, if I remember correctly. It's a protozoa.
Covered in cat feces, or
Sorry.
is that because they're covered in cat feces, or
Probably because they're covered in cat feces. Good clinical presentation again is a bit more specific. So they have rapid onset neurological defects. They can have confusion, personality change, and seizures. Clinical examination can help you locate where the neurology is. So in that picture, it wasn't exactly the scan that I saw on the patient, but it was very, very close. She had ring enhancing lesions literally right on the cortical spinal tract as it exited the pons. Good. What else was there?
There's the investigations and the treatment. So let's ask them what investigations they would do. So we've got our
good. What investigations would you do? So you've already done one, which is the imaging, right?
Yeah, good. So an LP, Sylvia. So
yeah. So you would always do serology on your LP. And it's PCR serology you do on the LP. Now, just a note, the PCR is very specific, so it can exclude toxoplasmosis, but it doesn't include it. It's not very sensitive. Okay. But majority of the diagnosis is made via imaging, clinical suspicion, plasma serology, and then CSF PCR. Okay.
And then, so the treatment ties in with the kind of investigation. So if we've got this woman and let's say her lumbar puncture doesn't show anything, she's got this whopping great ring enhancing lesion and she has a pet cat and like she doesn't wash her hands or whatever. What could we do? And what do they do in practice that would mean that you kind of can prove that it's toxoplasmosis?
I mean, you can treat for toxoplasmosis, and
yeah, so you do the house method. You do the house method. You prove it by treating it.
Yeah.
And so, what's the? Sorry, Mark, you go. You go.
No, it's fine. What is the treatment that we give? What's first line? Anyone know? Yeah, I mean, people don't really like doing brain biopsies. I mean, like really, really don't like doing. I mean, I've talked to a neurologist about this before. They just really think the idea of going near someone's nervous system with a biopsy needle is just a really miserable idea. So the easiest way to do it is to just treat to prove. But in terms of the treatment, it's sulfadiazine plus pyrimethamine, pyrimethamine, and folinic acid.
And so, yeah, definitive investigation. If that was in an exam, yeah, a biopsy or a post-mortem would be a definitive. If you had a negative lumbar puncture, but like if you had a positive lumbar puncture and imaging, that would be consistent enough.
Good. Okay, I've lost the slides again, but don't worry, I've got my slides over here.
So
the next one is a spot diagnosis.
Good. Yeah.
You guys put in the chat what you think it is, and then I think it's asking you how would you describe these lesions as well.
Fantastic. So yeah, Kaposi sarcoma, and how would you describe it to a dermatologist? I've only come up with two things really. So yeah, maculopapular.
Yeah, very good. Red, yeah. What's another? Well, it's not really red. It's more reddy purple. What's another word for reddy purple?
This is like lavage. It sounds really fancy. Violaceous, darling. Violaceous. So a violaceous maculopapular rash, Kaposi sarcoma.
Yeah, very good. So, Kaposi sarcoma, as I mentioned, it's one of the herpes, the human herpes viruses. It's number 8. Okay. Clinical presentation occurs when your CD4 count is less than 200. And it is a form of cancer. It occurs along Langer's lines. And if you don't know what Langer's lines are, have a look at your arm and squeeze the skin together. And you can kind of see the lines at which the skin runs, if that makes sense. You can kind of see the little lines of, how do I describe it? It's these lines that are just.
It's almost.
How would you describe it?
It's almost like the natural creasing. If you squeeze your skin together, it's the natural creases that form that aren't wrinkles, they're just creases.
Yeah, it's important. Surgeons like to talk about Langer's lines because you get best wound apposition. And there's another point is that Kaposi sarcoma occurs along Langer's lines, but it also occurs in mucous membranes. So it's very important to look in the eyes, have a good look in patients' mouths, okay, when you're examining them. And you can also get visceral lesions as well. So the diagnosis is you're going to do endoscopy. It's a clinical diagnosis visually. You can biopsy the lesion if you're uncertain what it is, because it can be sometimes mistaken for purpura, but usually purpura isn't as palpable. And then you can do endoscopy and biopsy of visceral lesions to confirm the diagnosis of visceral Kaposi sarcoma. Okay, and the mainstay of treatment is your antiretroviral therapy to reduce your viral load, increase your CD4 count. Okay, and then if it's quite severe or it's visceral, you're going to treat with chemotherapeutics as well. You don't need to know the specifics about the chemotherapeutics. Next, we're going to go on to talk about skin manifestations.
So these are a few spot diagnoses.
Yep, very good. These are your kind of classic ones.
Mark, I'm wondering if we finish here, just because it's on this side, because it's almost 7, and the last few things, we've covered a fair amount of content, and I think you could finish off your next session with the other.
I mean, to be fair, the other 3 are very specific things. I mean, you can have. We're gonna make the slide. The slides are public, aren't they?
Yeah, they will be. Yeah.
Yeah, I mean, we'll make the slides public. You guys can have a look at the last 3 slides because they're very, very specific ones. We've covered the kind of common stuff first, and then you can have a look at Mycobacterium disease, the other space occupying lesion, and Cryptococcus disease, because it's highly unlikely that you're going to be asked about that specifically.
But we can bring them. We'll bring them into a future session, just here and there. But
yeah,
these,
I
think we've covered the more cool stuff.
The next HIV session that I'll cover is going to be a lot shorter because it's going to be about the antiretroviral therapies and PrEP. So what I'll do is I'll chuck these last 3 in there as well.
Okay, so we've got some answers through for these.
Fantastic.
So yeah, we've got shingles. So this is a really good example of that dermatomal distribution, and so they can present with that and be more likely to get that.
Very good.
This one
is oral candidiasis.
Oral candida. So if we look at this person's face, if we look at the lesions, we can kind of see that they have this umbilicated appearance. And this would be an infection you'd be more likely to see in children. It's usually benign in children, goes away, very infectious.
So give us the name of the infection plus the virus that causes it.
Ooh. But does anyone have any ideas? This like umbilicated rash.
Yeah, correct, Jessica. Yeah, correct, Neuraj. What's the virus that causes it?
So it's molluscum contagiosum, and that's a type of what kind of?
Yeah, it's viral. It's viral.
Good.
Correct. Okay, I'll give you that for trying. It's pox virus.
Type of pox virus, yeah.
Yeah, it's a type of pox virus. Okay.
And so this one is a bit more niche, but let's give you a kind of a vignette and you might get it. So if you had someone that came to see you and it's them, their wife, and their child have all come down with this incredibly itchy rash, incredibly itchy, can't stop itching, not sleeping. And you can see this kind of lacy white rash in between the nail beds. In between the web spaces of the fingers, and that they've caught it from someone else. So yeah, so scabies.
Which and this type of scabies? It's a very specific type.
I mean, there's scabies and then there's like the other type. But so this is Norwegian scabies, which is just another type of scabies. This is not really something that like I don't think would come up, but I just found it quite interesting. But typical scabies does not go above the neck, so it doesn't affect the face, whereas Norwegian goes everywhere. So
fantastic. So yeah, good. So Norwegian scabies.
Yeah, good. So this is just illustrating that these patients can present with other infectious things as well, and so just keep an eye out because like you don't want to be touching someone's hands who's got scabies because it's just not pleasant like at all.
Okay, very good. And then your other infections. So you've got it, your VSV, your pox viruses, your HPV, bacillary angiomatosis. Very interesting. Just have a read about it if you're curious. Caused by Bartonella hensley. So you also get Bartonella hensley from cat scratches and cat scratch disease. Okay. Fungal your dermatophytes, your candida, your histoplasmosis, and then seborrheic dermatitis. But also just be cautious, because if you get into the mindset that all patients with seborrheic dermatitis are immunocompromised, you'd be very wrong. It flares up for people in stress. It can occur. So don't be fooled into thinking it's always immunosuppression. Good. Brilliant. Okay. The last 3 slides are, again, the rarer stuff. So I'll cover them the next session.
But yeah, we'll upload them. So we've got some Mycobacterium, got some space-occupying lesions, and we've got
Cryptococcus. It's all very straightforward.
We'll save it and we'll go through it, but these are much more like top tier things for finals, probably.
Yeah, you're definitely going to be asked the skin. Well, you're definitely going to be asked the skin manifestation stuff. Of any of the other infections, toxoplasmosis and PCP will be the ones that they'll chuck at you.
And it's also good just to know, we can put that in a future session, just knowing the CD4 counts that these typically occur at.
Yeah, so remember, below 200, you're going to get any opportunistic infection, okay? And then specifically cytomegalovirus, less than 100 or less than 50 severe, and the others generally between 200 and 100.
But that is the sort of thing you can learn a bit later in the year, I think. But yeah, so we hope you really enjoyed the session.
Yeah. Anyone have any questions?
We'll stick around, and we'll cover some more stuff in the future, and pop in the feedback what you would like for future sessions.
Yeah. So particularly, I mean, put in the feedback what you would like for future sessions in general, but like